John Marshall coming to you live, Oncology Unscripted, not from my office back in Georgetown, but from beautiful downtown Chicago, Illinois at ASCO 2025. Look at this amazing place, 40,000 of our closest friends. To get in, you need to have one of these. So I'm going to go ahead and badge up. I got a fancy red collar thing here. Boy, that makes me stand out even that much more. But what we're going to talk about today first is the social aspect. You remember, in anticipation of coming, we were a little worried about would people from outside the U.S. come to the meeting. And yep, they've come, but not to the same extent that they have in years past. So very clearly, international travel being affected by the world today, and therefore our community, which is so important to get together on a regular basis, probably being a little bit affected by this. But it is an incredible time to get together, to share thoughts, to give a hug or two, to shake a hand or two, and connect with those of us in our community who are dedicated to trying to cure cancer, to find positive outcome for our patients for Monday morning, for Tuesday morning, in the week ahead. So let's start with some high-level reviews of the most important science. Later today, we will have the plenary session where 5 abstracts will be presented, each one of which has significant impact on our patients going forward. Let's start in my world of GI cancer, where immuno-oncology, again, doubling down in the microsatellite unstable patient, adjuvant IO in MSI patients with chemotherapy proving to be better than chemotherapy alone, not tested against IO alone, which will clearly be the next question. But for now, starting next week, MSI high IO plus chemotherapy in the adjuvant setting in colon cancer. What about gastric cancer? Same thing, IO, and this is not an MSI, added to chemotherapy, showing survival benefit for our patients with gastric cancer. So as of now, as of today, new standards where IO will be added to adjuvant perioperative therapy for patients with gastric cancer. And the third area where IO has been shown to be a benefit in this plenary session is adding it to radiation and chemotherapy in head and neck cancer, something we've long been needing, improved novel therapies for head and neck cancer. IO has just entered that field too in the curative intent combo chemo RT setting. So 3 major places where IO is going to have an impact starting today. Now, I'm not even going to try to talk about polycythemia vera. I'm not even sure I can spell it. So I'm going to make you look that one up yourself. But I want to finish from a plenary perspective on this breast cancer study. Of course, it's always breast cancer. They are the smartest. They have the most money. They have the highest survival of all of our solid tumors. And yep, they did it again. They actually showed that if you monitor patients who are getting therapy, and you can use circulating tumor DNA, so a blood test that can demonstrate the emergence of resistance before there's a change in the clinical scenario. And if you add in this case, an androgen hormone degradator, that in fact you can intervene and actually extend survival and progression-free survival significantly. So this is real-time monitoring using novel blood tests for resistance and changing your therapy in advance of any other clinical signal. Clearly, this is the way things are going to be going more and more as we define therapies for our patients, not so much using CT scans and waiting on progression, but blood tests that demonstrate resistance at a much earlier time point. 2 other important GI papers, not part of the plenary. There wasn't room for everything in the plenary. And this is, guess what? It's now good to be BRAF colon cancer. Do you remember when it used to be bad to be HER2 positive breast cancer? Do you remember when it used to be bad to be MSI? Well, it's not bad anymore for those 2 because the therapies work. It used to be bad to be BRAF V600E mutated colon cancer. Just a bad prognostic sign, nothing you can do about it. study just presented showed that the addition of BRAF targeted therapies in frontline metastatic colon patients, 30-month median survival. So that took a bad marker. We can now deal with it. What does that mean for your clinic? I'm going to be strong here. It now means that it is malpractice. You are not practicing the standard of care if you're not doing frontline molecular testing in colorectal cancer. You are obligated to find RAS mutations, BRAF mutations, MSI, and HER2 before you initiate treatment. So this positive BRAF study affects standard of care in your practice today. So you have to do that going forward. There was a study looking at a novel local therapy for pancreas cancer called Tumor Treating Fields, and that showed some positive data finally in pancreas cancer. So that's exciting. Tomorrow morning, we'll be presented frontline in HER2 data for patients with HER2 positive breast cancer, showing dramatic deltas and PFS and OS when you initiate treatment within HER2 instead of the traditional therapies there. So practice changing common cancers, precision medicine driven, IO driven. It's a dramatic year for new data, new standards of care being presented here in Chicago, ASCO 2025. John Marshall, Oncology Unscripted.